You can start.
We are live.
Okay. So welcome everybody to this All India Ophthalmological Society Scientific Committee webinar. And today we are going to be dwelling on a topic which is an enigma for everybody, including the cornea specialists. And more so, not only its primary pathology, but also the treatment. The topic of today's webinar is immunomodulation. How does it change the landscape of ocular surface disease treatment? And we are going to have a couple of talks first, followed by the panel discussion. I have with me illustrious speakers, Dr. Rohit Shetty, who is going to be giving his talk. He needs no introduction, and Dr. Bhaskar Srinivasan, who's going to be giving another talk on levetiracetam. Apart from this, we have expert panel, Dr. Sujil Shah, Dr. Ayan Mohanta, Dr. Varki Shibu, Dr. Sovik Banerjee, Dr. Rajesh Sinha, Dr. Madhu Dairaju, Dr. Samresh Srivastav, Dr. Pooja Khamar, Dr. Aditi Agarwal, Dr. Samita Mulani, Dr. Abhishek Jiu, and Dr. Achal Gupta. So without much ado, I would request Dr. Rohit Shetty to give his talk. The title of his talk is Immunology and Ocular Surface Disease, Research to Clinic. Thank you so much, Dr. Rohit, for doing this. We know that you have just returned from abroad, and thank you for fitting this into your very busy schedule.
Thank you, ma'am. Thank you for everything. I think the presentation is with Navneet. If you can present it, please. Some work on immunology and ocular surface disease from research to clinic. Hello, friends. I thank the AIOSSC for this wonderful opportunity to share some work on immunology and ocular surface disease from research to clinic. These are my financial interests. I do not have anything directly or indirectly linked to the products I'm going to speak today. One of the major challenges today is changing lifestyle is making the immunology to change. It's a very complex nexus. And changing lifestyle in all aspects, the diet, the stress, and all the microbiomes which changes in your body. See, what really has an impact is the factors which have an impact on the ocular hemostasis, which includes the environmental factors, the healthcare access, economic stability, the social profile, the food we eat, and ocular microbiome. But that changes the whole complex of the virus, bacteria, and the fungi, and how it has an impact on the ocular surface. The immune landscape is completely changing from an immunological point of view. For example, when I started doing my confocal work in 2005, close to 20 years back, this used to be the corneal nerves, absolutely clean. There's absolutely no changes. If I went back and started seeing a few years later, there's been some people with contact lens intolerant who would have a different corneal nerves. And in 2010, I started noticing these small cells, which we used to call it as a dendritic cells there. And as it kept increasing, I can see that there is a huge change in the landscape of dendritic cells. And then close to around 65% of my patients, I would examine them on slit lamps, would have dendritic cells. And then later, there's an interesting paper which spoke that these are all T cells and not just dendritic cells. And then came COVID, then everybody has filled with dendritic cells, which just shows changing type of inflammation in your ocular surface. This change also have an impact on how the epithelium heals. For example, these are your cells. This is how an epithelium is showing different thickness. This is how the clumps of cells which is out there. And here, these are different, mix of dendritic as well as the T cell. Look at this. This particular eye is filled with only T cells, and this is dendritic cells, which has more extensions, and these are the ones which will show different level of hyperplasia changes before or after surgeries. This is a colleague of mine who shows so many dendritic cells, T cells. Then there are some microneuromas around here, which suggests how much of immune changes. And this is not a contact lens wearer. So there's no contact lens, but just a simple ocular surface patients who has a lot of signs, a lot of symptoms, but no signs. And now we are also with this new change of new dimension OCTs, we are able to measure a lot of things very carefully. For example, this is your epithelium, this is your Bowman's. But what interesting here is there is one dark layer here. This is your basal cells, which kind of extends to your limbus. These are highly metabolically very active cells, the basal cells, and then these cells will pump in the other superficial and wing cells. And this is your Bowman's out here, just above this Bowman. So it's interesting now to see how this ocular surface has different types of cells and how this layer, which is close contact with your palisades here, the limbus, would behave to a particular stress and behave to an inflammation. We had to really look at predicting the biological response because your ocular surface is the major factor which is affecting the quality of life, both post surgeries, and many ocular surface issues. The immune modulators and immune mechanism is something which is very, very important for us to understand. This is from your TFOS, everybody is aware of it. And we had to really look at, this is a triaging questions and how we have to look at different new concepts of neuropathic pains and pain without stains now. The phantom symptoms are something which is very, very common in our practice today. And these are the phantom symptoms: anxiety due to dryness, my eye hurts when it's wind, excessive pain, excessive watering. I mean, imagine you do a good surgery with the cataract or refractive and end up in all these challenges. Is quite bothersome to the clinicians. Many of them are driven by ion channels, which are the mainly in your, these are present in your ocular surface, both the cornea and the conjunctiva. They're voltage gated, the ligand gates is mechanosensitive is something which is very important. We did write a very nice paper on ion channels in dry eye and what triggers them. And these trigger factors have a huge influence on your phantom symptoms. Then we had this age of immune mimicry, I call it, which is the long COVID, vaccination, post-COVID status. And we know that these COVID, the last 3 years, change the complete immune dimensions. And when you look at outcome of, say, refractive surgery or something, which is 80% is predicted, 20% is unpredicted outcomes, which could include ectasia, scarring, dry eye, and multiple other things. And these 20% unpredictable outcomes have a huge impact of altered immune profile. And this is very important for us to be aware of this. And these immune profiling or alteration has an impact on how the cornea heals. And this healing, in turn, affects the extracellular matrix, the scarring, the regeneration, collagen synthesis, and multiple other factors. This is just ocular surface immunology of a patient undergoing cataract surgery. You can see that these are pre-cataracts. So these are not even after cataract surgery. You can see that there's tremendous amount of changes which you see even before you use the phaco machine, even if you make an incision. That means that the eye is filled with inflammation. And if I go back and look at 10 years data, this is double of what it was then. These are PRK patients, which also have a lot of these markers, which can end up in scarring. Now, how do we identify them? And that's where the whole concept of biomarkers comes into picture. And we have worked on this biomarker pathfinder, where you look at a simple tear film and try to identify all these molecules, which might have an impact on your outcomes. For example, inflammation, the scarring, extracellular remodeling, and the collagen synthesis. And this could happen in all aspects of ocular surface, whether it's your dry eye or it's your post-refractive surgery, PRKs, cataract surgery, or including glaucoma. Sometimes, if you have a high level of TNF or TGF-beta mediated pathways, you might end up in a more fibrosis, which can end up in failures to your trap. You can also use from the aqueous or vitreous. This can help to give the same reports, and we have used it for multiple other branches also. So what is interesting here is that higher level of TNF alpha in cross-linking has slower healing, more scarring, more haze, and this has a huge impact in patients undergoing excessive flattening or some other changes over time. It also helps us to identify and do a titration treatment of exactly what drug would use. For example, ICAM1 is lifitegrast trohelose. You have an TNF alpha when intense IPL therapy worked very well. IL-17 therapy works well. And IL-6, we have used, Lipiflow works very well with Mivoflow. And these are all, pathways where it's like how you use your antibiotic sensitivity. We use this to look at different sensation, to look at different, altering your ocular surface immunology. So I use this word biological cleansing, where we're trying to use this to stabilize before you do any procedures. For example, this is a patient of mine. I did an uneventful LASIK smile lenticle process surgery, and one eye was normal 620 by 20, other one has 618. So I use this is a pentagram OCT, which is probably the highest resolution OCT in the market today, because it gives you a tear film. It gives you beautiful here, the basal epithelial level, and then it gives you the Bowman's. So what is interesting with this one resolution micron OCT is it has a tear film. The superficial cells, you get more reflective here, then your other two layers, and then your layer of your basal epithelial cells. And there you see that here there is some amount of edema here, which you don't see here. What does it mean? That there is a subclinical edema which picked up here within 1 micron resolution OCT. Sometimes the normal OCTs don't pick up because these are very fine edema which is just at the keratinocytes level. And when you see them, this patient is actually, because of the edema, is pushing the cornea up a little bit, and that is creating that visual drop, which is significant. Now, why did he have that? If you look at this, he has a high level of ICAM1 and TNF alpha. And this is something which is very important, that these things have an important factor. And he also had a high level of epithelial thickness pre-surgery, which means that there's some changes which was happening. And these factors could have an impact on the outcome of your refractive surgery or cataract surgery. So because of this, there could be more stromal edema, there could be more keratinocyte changes, and that probably if you don't treat them well, it will end up in more of exaggerated response, which could have more of epithelial changes. And it's also important that when you have a high level of inflammation in your ocular surface, the corneal nerves are not healthy, and you do any surgery, the nerve regeneration is very poor. So when you have a poor nerve regeneration, you end up in more epithelial changes, you end up in more irregular corneas, you end up in coma, you end up in different changes, which is not good for the outcome of surgery. So one of the things we do is we try to treat them before surgery with immunomodulators, so that you can reduce the inflammation, so that the nerve regeneration is better. When you have a healthy nerve regeneration, the hemostasis between an epithelium and nerve and how it has an impact on healing is phenomenally different compared to a poor nerve healing. Now, how do you target these biomarkers? I did mention there are TNF alpha is a pro-cytokines, pro-inflammatory cytokine, is a pro-inflammatory cytokine, TGF beta, which has a huge role in extracellular matrix, remodeling, and including have some effect on the scarring. So basically, what we are looking at today is trying to harness the T cell responses, which is very important because that's where the response triggers off a change of cytokines and other factors. So one of the major factors we're studying is the molecule called lifitegrast. The lifitegrast works on the T cell. Every T cell has an LFA, which is a receptor, and then ICAM1 is a cytokine which comes and it has to bind to that LFA, and then this other materials are released. So lifitegrast blocks this handshake. That means it blocks the handshaking of a receptor with the ICAM1. So what are the differences? The cytokine acts in the cytoplasm. Cyclosporin acts in the cytoplasm inside the cell. The lifitegrast dampens the activation of T cells because this is your cell, this is the LFA, this is your receptor, and the antigen presenting cells will come and they would try to do a handshake. It blocks this. So it is on the cell surface. So cyclosporin and lifitegrast are two different mechanisms. So that means technically both can be used together because one on the surface, one on internally. Lifitegrast also has an earlier onset of action because it works on the surface. So earlier you start, it probably would work better than probably using a little later. That's something which is, and lifitegrast on all the cells with LFA1, which is most of the immune cells. But cyclosporin acts on all cells, wherever the calcineurin is present, because it works on the calcineurin pathway. Lifitegrast works on the LFA. The LFA is the receptor which you need. This is a simplified version of, this is how there is a difference of work. And this is what I said, that antigen presenting cells, which has an ICAM1, and the T cell has an LFA1. So what happens normally is these come and do a handshake. When you have a handshake, that is what creates tremendous amount of T cell mediated response, which causes activation with other cytokines and other things. Here, by blocking it, you block it so that there is no activation of the cells. Let's see how it works. This is one of our patients she's a doctor by profession, had a contact lens intolerance, post-conjunctivitis, multiple treatment with bread foods, but still not happy, not improving at all. And she still had all these parameters with a lot of PE, very, very unable to work. So when we looked at it, she had deficiency of vitamin D and B12, which we treated. But what interesting in the biomarker report is, look at this, every single marker is high. Remember, she's been on steroid for 2 weeks, close to 2 weeks. The steroids is not targeted therapy. It did not work on any of it. More probably it was not targeted, or probably it is something which even now I don't know. But when we use the lifitegrast for her, and what I see is that the complete response is completely different. So that you can see that the same person in a week's time, the whole of this time, this is the AI report. You can see how bad the AI report is, and look at this. And look at this, is completely, the entire thing has swung, and completely in a week's time, she's better. That means that just because we have steroid, it doesn't mean that it should work for everybody. There are very specific therapies which works wonderfully well, like in this person. When we look at corneal fibrosis, there are different types of treatments. Today we are using mitomycin. We have we have losartan for it. Even beta blockers have some role in it. So there are a lot of work on the TGF beta pathways. So we work on a complete wound healing pathway. We have a SWAT team. We looked at a combination of trehalose with the lifitegrast, and we feel that lifitegrast also has a TGF beta activity in scarring. And we did some experiment on this, and we feel that maybe its action on inflammation or maybe action on the TGF pathways may have a role in as adjunctive scarring, or in trying to reduce it's an anti-scarring, anti-fibrotic properties, or it can be used when you use cross-linking when you use for PRKs. Cross-linking, you need a little bit of scarring, so using lifitegrast or losartan may not work because it will do the opposite and you may not get the cross-linking. So maybe trying to use it in PRKs or post-infective or post-cross-link, post-infective or post adenoviral, it might have a role in reducing the TGF beta activities. And this is one of our patients. Again, I use the pentacam OCT here. The reason is, and if I use any other OCTs, it just gives you this picture, but here I can see a very nice scarring. And this is just after a month. You can see that with the lifitegrast, the scarring has reduced and it's getting more organized. We need better OCTs because when you have a better OCTs, it picks up much better than what you see in normal OCTs. So these are all the important factors. And what I want to sum up here is that the cornea, conjunctiva, and all the ocular surface is filled with immune cells. The immune mechanism is changing. Immunomodulator targeted therapy is the way to move forward. And we have to understand how these immunomodulators work and how we can harness them in our practice. Thank you.
So I think that was a excellent presentation, Rohit. It is not easy to condense so much about ocular surface, understand it and put it across. And I'm sure there are going to be a lot of questions. So if any of the panelists wants to ask any question regarding the presentation, if anybody would want to ask anything. Yes, Dr. Han?
My question to Dr. Rohit Shetty is a lot of echoing. Hello?
Yes, I am.
Yeah. So how do you see the possibility of using lifitegrast in dry eye patients with cataract or LASIK surgeries?
Sir, lifitegrast by nature, like I mentioned in the presentation, works in the very early stage of T cell response. So where the antigen presenting cells, the dendritic cells, and the T cells when they interact. So many times in your refractive or cataract surgeries, your insult of the surgery makes the patient to have a cascade of cytokine release, which causes all the others, dry eye and multiple other challenges related to it. So when you use this, you are actually blocking that cascade at a very early stage. So I feel using it is good, and to block the whole cascade there, both in post-refractive and post-cataract surgery. Also, it has a role in premium cataract surgery when you use it maybe a week before. And if you are feeling that there are a lot of ocular surface changes, they are on rheumatoid or any of these things, they have a big role there. But I also see a good potential of using lifitegrast with cyclosporin in chronic dry eye patients because the cyclosporin works in the cytoplasm and the lifitegrast works on the cell surface. So when you combine them, the effect of modulating the inflammation would be much better.
Dr. Rohit, thanks for your nice presentation. Can you hear me?
Yes, we can hear you.
Yeah. Okay. So the paper is already published in 2020, effect of lifitegrast on refractive accuracy and symptoms in dry eye patient who will undergo cataract surgery. So it's a paper that determined the improvement of the tear film, the in-fact biometric keratometric value, and the refractive accuracy for dry eye patients scheduled for cataract surgery. And the lifitegrast usually scored higher than cyclosporin in the study.
I think what Dr. Rohit is saying is a little different. That is, we can use a combination therapy also. And
Madam, just one point is that if you talk of the studies, either Opus 1, 2, 3, or any other studies on leafetigrast, the study precondition was that concomitant use of any artificial tear or cyclosporine was prohibited.
was prohibited because they wanted to understand the effect of
Yeah,
liver.
yeah.
It was not prohibited because they have an antagonistic action. So they wanted to look at how lifitegrast works. That is why it was excluded. Am I correct, Rohit?
Yes, ma'am, absolutely. Because like any study of any kind, they would only want to use a monotherapy because they don't want to have a confounding factors with it. But for our understanding, the pathways of lifitegrast and cyclosporine is completely different.
Completely different, yes.
So they can be an synergistic use rather than a separate one.
So there are some questions also from the YouTube channel, and it is one question is that can we use lifitegrast in cases of chronic allergic conjunctivitis and VKC?
See, lifitegrast works on ICAM1 and ILS. ICAM1 is a very strong molecule, like cytokine, which is involved in itching and various allergic potentials. And ICAMs are not really modulated very well with steroids or anti-allergic. Like mast cell inhibitors don't really modulate them. They don't really. So I would see that there is a huge potential for VKCs. And I think because it stops the itching. Even in keratoconus patients, it has a good potential to stop the itch. But only thing is you have to use it at a very early stage. Chronic stages, you may have to combine with cyclosporin because chronic stages has gone through a multiple cascades. So it may not have a biologically, I don't see a sense to use it at a very end stage.
So that I think answers Dr. Kanika Bhardwaj's question, and everybody, I think we have one of the highest audiences today at all our channels, and congratulations congratulations to Dr. Rohit Shetty for this presentation. So many people are watching. Another question is that Dr. Saurabh Luthra wants to know I think about the machine that you talked, and that is the Pentacam OCT. So Pentacam OCT is something I think which is new. Would you want to just comment on it? And also about the various markers and whether they will be commercially available soon or not.
The Pentacam OCT is something we have been working with Oculus for close to a year now. And the Pentacam OCT will have an OCT along with the Pentacam. So it will have a full-fledged. The OCT is very unique because at this point of time, no commercial machine is giving you a resolution of 1 microns. It's probably the 1.1 or 1.2. So you have the finest resolution known in OCT market today, commercially. Of course, we have the non-commercial one with the PS polarization OCT, which has again one, but that's not commercially available. So we are working on a project to write the software for this OCT, but you can still buy the OCT now. It is what is unique here is that you can see a lot of structures which was never seen in any other OCT. For example, the basal cell layer is a beautiful one. And in some patients, you can even see possibly a Duas layer. You can see a pre-Descemet's layer. The ability to understand the Descemet's is very different here. And the Bowman's is very clearly defined. And the reason I use this particular one here is because, especially when you're looking at healing responses of scarring or many of these things, there's a difference when you see a 6 micron resolution OCT versus a 1 micron resolution. And the second one is question about the markers. I think this is where Namrata ma'am is really helping us to. Now, the India, you cannot bring anything without proper studies. The complete culture of bringing any product to market has completely changed. And now it has to go through multiple level of testing. Thank Namrata ma'am here officially for helping us to bring this Indian product to the market. First, it has to go through certain government colleges have to approve it.
So I think it will be there very soon, and there are at least 3 or 4 people who are asking when it is going to be available. Then there is another question which is there, and what are, I think we can maybe take it now only. What are the major or significant side effects with lifitegrast?
Little bit of stinging, I mean, very minimal, which we have seen compared to what I've seen in the previous other drugs. A little bit of, some people have complained that it causes a little bit of some taste disturbances because maybe from the absorption, but not all. So far I've given for the last 8-9 months, not anything which is significant. But one of the advantages of lifitegrast, what I've seen is when it works very fast. See, unlike unlike your cyclosporin, sometimes when you time, it takes a little time for it to work. See, it works like steroids, but not the side effects of steroids. And like I just showed one of these cases, it works very well in when you, especially this conjunctivitis, post-conjunctivitis sequelae is a wonderful drug because post-conjunctivitis sequelae is driven by all the markers, and the steroid somehow doesn't work, especially the scarring and all. And what I see a collateral, nobody has really spoken about it. What I see a huge impact is it has definitely an anti-fibrotic role. So if you're looking at any post-infectious scarring or anything, I feel because it has a strong TGF-beta mediated response, so which I feel is a fantastic role for scarring. The only place I would not want to use it is a post cross-linking, because it will do the opposite of what cross-linking is doing. The duration of treatment is, I would give for 3 to 4 months, but 3 months would be what most of my patients are happy with. Chronic eye rubbing, children with VKCs, all T-cell mediated response, wonderfully well.
There's another question, and that is what to start it pre-operatively. Then how long, would you start it pre-operatively? And I think the post-operatively, you've answered the question already that you would like to give it for at least 3 months. But pre-op, if you have to start for someone in refractive surgery or cataract surgery, then for how long would you want to give it?
If I'm doing a PRK and I'm very concerned about haze, if it's a contact lens intolerant or very dry eye patient, I would start for 2 weeks. If I'm treating on a very bad meibomian gland dysfunction in a LASIK when there is more than 50% dropout, then I would start for a week. Cataract patients, a week would be good enough, because what I've seen is that by the 4th or 5th day, a lot of biomarkers comes down. So I realized that unlike sometimes even steroids take 2 weeks time for it to come down. For some reason, it comes down. The doctor's report I showed, whose markers came down just in 5 days, and she's been on steroid for 3 weeks. So, and she completely because all her symptoms resolve very fast. She's an ophthalmologist. So, I mean, I know that she's giving me the right response.
Yeah, Dr. Rohit, what's your opinion about using it in keratoplasty patients, post-keratoplasty?
Sir, the post-keratoplasty, it has some it has some action on vascularization.
Okay.
So, because it has a vascularization agent, so it does have some role, but it's not been studied. But if you ask me from a biological point of view, it's a very good drug. But you should probably look at it combining with cyclosporin there.
Because after your presentation in Goa, I've been routinely using it in my high-risk keratoplasties.
It will work. It will work.
Yeah.
Because see, keratoplasty rejections are all again T-cell mediated. You know, it will have its impact there.
As a rule,
Yes, Samita, you wanted to ask a question?
thank you. As a role in late haze for PRK patients, or even chronic scarring post-viral, as you mentioned during your presentation as well, how late do you think, if one plan to start it, like if the patient comes to you 6 or 9 months after the scarring or the haze, do you think that it would have a role? And
the gentleman I started it, he came from the one I showed my presentation in. He came to me 9.5 months after he has got a scar in, he comes from England, and he had a post-infectious contact lens induced scarring. So he came back. This is what I just showed 1 month, but he came back 3 months, 4 months later. It's 50% gone. And you have to combine with Trehalose, because any Trehalose like Trehalube with this one is, I don't know, just per se, it may have, but Losartan is the best. If you're looking at, but Losartan, preparing Losartan is a very cumbersome process. And Indian Losartan tablet don't dissolve very well. So we prepare in the lab. But when you don't have a chance to use a Losartan, I think Lifitegrast with Trehalose works the best. And when you use it in an early stage of post-adenoviral scarring, because a lot of those scars you get are all TGF-beta minor pathways, and that works very well.
Yes, I fully agree with you. We have got a very good result. Another quick take is, sir, in the Indian context, there are a subset of patients who really don't do good with the cyclosporine, and we often use tacrolimus. Do you have any experience of concomitant use of tacrolimus and Lifitegrast?
See, the tacrolimus is more potent. This works on the same calcineurin pathways.
Yeah.
Maybe it is more potent than your cyclosporine.
Yeah.
But what is important here is that the band of action of cyclosporine is different compared to the band of action of what a Lifitegrast. For example, there are certain molecules like IL-1 betas, ICAMP and all, the cyclosporine is not a great action on it. So this works very well. So sometimes tacrolimus and Sika, the Lifitegrast also works well. It's a combination. What you have to understand is the Lifitegrast works on the cell surface. The cyclosporine works inside the cytoplasm. So when you combine both, the action is always additive. But when you're working on a cell surface, it's an initial action which is important. That's again why Dr. Worky said, Shibu mentioned about keratoplasties, and when you have an acute reaction, it has a potential role there.
There's one more question. Regarding scarring related to HSV keratitis. You think, Rohit, I don't have any experience on this, but do you have any experience, or can it be tried, or do you think could it trigger a acute HSV, or should we or not use it? Especially because it works on the surface, and if you have, scarring, that will be more because of the epithelial and the stromal component of the herpes keratitis.
Ma'am, what happens is when you use Lifitegrast with Trehalose, Trehalose has an interferon action. So Trehalose also has some action antiviral properties in it. We published an IGO during COVID. Trehalose has an antiviral properties which has an action to reduce the viral COVID load in the ocular surface. And this was published in IGO. So if you combine with Trehalose and Lifitegrast, the action of reactivation of viral may be reduced by the Trehalose component, and it does not change the immune. It doesn't dampen your immune response. It only works on the extracellular matrix, which causes excess fibrosis. So it is more of an anti-fibrotic component there, and it's not just an immune dampener there. So I may be wrong, but what I'm saying is biologically, it should not do anything on the viral reactivation.
Achal, Dr. Achal Gupta, Achal, you wanted to ask a question?
Hi, Dr. Rohit. It is really insightful first, because mostly we are tunnel vision to think that the immunomodulators we would limit to inflammatory dry eye. But yes, it opens a plethora that it can be used in so many other conditions with added benefit. But I would like to ask from you that, do you set a mental timeline for post-LASIK dry eye, that you would start the immunomodulators after a certain duration of trying on with steroids, or how do you go forward in such cases? Let's say we have a patient who's post-LASIK and he's really irritated with the dry eye.
Says it depends on geographically which part of the India you're from. If you're from this Hyderabad, Bangalore, virtually you have everybody who comes and tells me they're 12 hours, 14 hours working. If you just look at the meibomian glands, there's hardly, I have not found anybody who has a full gland profile there. And second is my work of confocal from 2005 to 2025. If I look back at all my images, our immune profile has completely changed. I see only T cells in your corneal confocals now, which means that everybody is loaded with unwanted inflammation. Whether it's your diet or whether you with your computer, we don't know. So I keep them on either cyclosporin or lifitegrast, one of the thing for 3 months for everybody. The reason is they believe but only difference which I do is if they have a very bad ocular surface, then I pre-treat them 1 week prior. For my pre-treatment, I use lifitegrast more because it is very fast acting and it's very acute in its action. So I can treat 1 week prior and then do the treatment.
Dr. Namrata, will we accept it as a paradigm? Because at least here in India, I don't think that we are using immunomodulators as a routine of our post-refractive surgery regime.
So I think it is a paradigm shift. There are studies. We've also done a study post refractive surgery patients, cyclosporin versus chloroquine. So I think I'm not saying that it has completely changed the way we give routine medications to post refractive surgery patients, but that is something which needs to be proven by studies. But yes, there are studies which suggest that you may use immunomodulators, especially after refractive surgery.
There is one question somebody, I think I didn't see the name. The doctor has asked about cross-linking.
Yes.
I would not use lifitegrast in the initial phases because it is directly opposite of cross-linking. So you would not want, if you want an effect, it is the complete opposite. So you would not want to use it. But if you want to look at late phase, and then you probably combine it maybe after 8-9 months when you have a regeneration of when your new set of collagen is keratocytes have come back, you can combine it with lifitegrast with trehalose, because I use the word trehalose multiple times because trehalose is a very strong TGF mediated pathway. Apart from a lubricant, it is a wonder drug in terms of what it does on the TGF pathway. And trehalose itself, post surgery, it is a synergistic effect. Trehalose helps in apoptosis, cleansing the apoptosis, so it is not going to have any effect on the cross linking. So if you can use trehalose as a post-operative drops, and then later, if his scar is very bad, then you can look at lifitegrast.
So I think, thank you, Rohit. We've covered so many aspects of lifitegrast, cyclosporin, tacrolimus, and all the immunomodulators which are available today. Thank you so much for that fantastic talk. And with this, we'll come to the second talk, and that is going to be by Dr. Bhaskar Srinivasan, and he's going to be talking to us about the molecule that we are talking about today, and that is lifitegrast, a novel immunomodulator.
Thank you, Dr. Namrata. And I mean, quite a bit of the topic has already been discussed when we have had the question and answer session. So just to kind of reinforce the concept. So we are going to be talking about lifitegrast as a novel immunomodulator, no financial disclosures. So basically, we all know that when you're looking at dry eye disease, inflammation does play an important role. And it's not just a Sjogren's or an aqueous tear deficiency that causes inflammation. Even a meibomian gland dysfunction does have an inflammatory effect on the ocular surface. And if you're just going to be using lubricating drops, it's not going to solve your problem because you're not going to the root cause of the disease. And this basically, when you're looking at the immunology, as Rohit has nicely said, you have the desiccating or the increased osmolarity, which causes an increased activation of the antigen presenting cells. These migrate to the lymph nodes. They stimulate the formation of T cells. These T cells then get released and come back through blood vessels into the ocular surface, and they then cause their effects. So you have basically an innate immune arm and you have an adaptive immune arm, and both of them actually sync together, and that is what reinforces the inflammation and causes the inflammation that we see in a dry eye disease. So just to make it simpler, an activation of the immature antigen presenting cells leading to them becoming mature, they then goes into the adaptive immune arm, and this not just promotes increased vascularization and increased inflammation on the surface, it also promotes lymphangiogenesis. So that basically again triggers off further wave of cells which will migrate from the ocular surface back to the lymph node. So when you're looking at inflammation, you have an initiating a process of initiation, a process of amplification, a process of recruitment, and then finally the cells cause damage, and then this cycle gets completed. This was published with respect to cyclosporin, but when you're looking at an ocular surface disease and dry eye, the basic pathology remains the same. Whether you use cyclosporin, whether you use lifitegrast, depends on which part of the immune cycle are you targeting. So as said, the experience with cyclosporin has now been almost close to 2 decades, and we know that it binds to the calcium calmodulin complex and reduces the activation of the NF-AT, and that basically is in the cytoplasm, and then it goes into the nucleus and then triggers all the cytokine release. So both tacrolimus, which acts on the FK506, and cyclosporin act inside the cytoplasm, as mentioned by Rohit, on a slightly different pathway. Whereas when you're looking at the drawbacks of cyclosporin, the problem was the fact that it is not water soluble. It had a significant stinging and burning sensation on instillation, and because it was so uncomfortable for patients, in fact, in Japan, they don't use cyclosporin for dry eye as such. They in fact use the topical formulation of tacrolimus there for dry eye as compared to the rest of the world. When you're looking at the survey around 2010, when cyclosporin still was about 8 to 10 years into the market, ophthalmologists did feel that we needed something more. The reason was also because it took a little bit longer for cyclosporin to start acting. When you're looking at the recent advances, around the same time, around 2013-14, people started looking at the lymphocyte function antigen and the ICAM interaction, and they realized that this is a very, very key factor which drives the T cell mediated inflammation. And like we said, there is a handshake between the LFA and the ICAM, and then there is a handshake between the TCR and the MHC complexes, which is there on the antigen presenting cells. And this is what causes the immune synapse. And once this happens, you have a wave of inflammatory cascade which sets in. So the idea is to break this bond or prevent this bond from happening. So these are just two diagrammatic examples taken from this publication, where it shows that when there's a desiccation of the ocular surface, you have increased presentation of ICAM, not just on the ocular surface epithelial cells in the stroma, but even in the blood vessels which are there. And if you have T cells coming in, they will then reach and bind to these ICAM and cause inflammatory response. Now, if you're giving lifitegrast as it enters into the epithelium and into the stroma, it will bind to the T cell, preventing the bonding of the T cell with the ICAM, thus preventing the release of cytokines that are toxic to the ocular surface. So development of lifitegrast as a T cell targeted therapy, it stops T cell activation directly, inhibits secretion and release of pro-inflammatory cytokines. So when you're looking at lifitegrast, it's a small molecule. It was FDA approved for treatment of not just signs, but even symptoms of dry eye disease, because in the initial FDA approved FDA study also, there was an improvement both of signs and symptoms of patient. It is administered a topical ophthalmic solution of 5% concentration. It strongly inhibits the adhesion of T cell to the ICAM, and it has a rapid absorption. Because it's an aqueous base, it has a rapid absorption into the ocular tissues. It also has a rapid clearance from the systemic circulation, so you're not worried about the toxicity of a systemic absorption of the drug. So it has excellent pharmacokinetic properties, and with this you would expect it to work in ocular tissues. And this is the reason why we are kind of very interested to know that whether it's only dry eye disease or various other T cell mediated diseases that we are talking about. And we had the discussion on allergy, we had the discussion with corneal transplants, we had the discussion with antifibrosis, wherever we feel that the T cell response is important in triggering or running the inflammation, we would probably want to look at this being a source or one of the options that we would have. Having said that, we don't have studies which have proven. So the use apart from dry eye is all going to be off label, whether you say adenoviral scarring, whether you say graft rejections, whether you say allergic conjunctivitis. At this point of time, it is an off label indication. It's not been proven conclusively, but the biology of it is such that we would expect. It's similar to how we started using cyclosporine initially for dry eye, and then we said, okay, fine, it probably works in allergic conjunctivitis. But because cyclosporine was not tolerated, then we shifted across to tacrolimus. So each molecule has a way, and the biology of the molecule tells us that in this particular disease groups, it might work. The details in terms of how early you need to start, how long you need to continue, what are the other side effects in terms of long-term use is something that we will probably be looking at later on as we get more and more data about the same. So when you're looking at the studies which were done to make lifitegrast available, it did prove that there was excellent bioavailability. And like Rohit said, the onset of action was pretty fast as compared to cyclosporine, which took a couple of months. And the long-term safety and tolerability was also pretty good. So in fact, when they compared and asked the patients in terms of whether it reduced their dependence on artificial tears and steroids, this study did say that the use of lifitegrast reduced the dependence of patients on use of artificial tears and steroids. When you're looking at aqueous tear deficiency, yes, we all know with the role of inflammation, but even like I said, even in a significant MGD, inflammation plays a role. And here in this study, they compared the role of thermal pulsation versus lifitegrast and did find a beneficial effect of lifitegrast. So any damage to the ocular surface with respect to desiccation is going to induce inflammation, whether it is aqueous deficient, whether it is mebumin gland dysfunction. So you would want to treat the inflammation with whatever options that you have, whether it is thermal pulsation, whether it is IPL, whether it is lifitegrast, whether it is cyclosporine. When you're looking at the study which was published from India, and this has been published in AIOSSC, they looked at comparing the outcomes of lifitegrast versus the CMC drops, and this was a multicentric double-blind parallel group study. And what they found was that the use of lifitegrast significantly reduced the symptom score, especially in terms of eye dryness score, ocular surface disease index. It improved the sign score in terms of tear breakup, Schirmer score, and corneal fluorescein staining scores as compared to CMC. So it tells you that yes, compared to a CMC, lifitegrast is definitely better. But obviously, we don't have head-to-head comparison of lifitegrast with cyclosporine or lifitegrast with tacrolimus to tell us this is better or this is better. Each molecule has its role in our treatment, and like Rohit said, each work in a different manner, and there would be occasions where you would want to combine both to get the best outcome. So in this study, they did show an improvement in the OSDI scores, and you can actually see the improvement starting in about 2-week period. The tear breakup improved again in 2-week period. So with lifitegrast, the advantage is a faster response to your treatment, similar to what you would expect with the steroids. Why do when we give cyclosporine, we normally start off with steroids and cyclosporine more because we know cyclosporine takes a little bit longer to act. So we want to kind of make the patient comfortable in the initial period with the topical steroids. With lifitegrast, because the effect is pretty much equal to what cyclosporine gives in the first couple of days time, you might not want to add a steroid in the early 2 weeks. You might not want to add a topical steroids as such. Adverse effects are not much. You do have irritation, installation site burning, which people do repeat. And some patients do complain of what is called as dysgeusia, basically an altered taste sensation, but none of them were significant. And it was almost similar between the group that got the CMC and the group that got the lifitegrast as such. So lifitegrast has been, in this study, they said that it's definitely better than CMC in all group and various symptom and sign scores were improved. And this was purely an Indian study, and we need to know data from an Indian population for us to be very clear that yes, this works in our in our population. So when you're looking at a review, this was a systematic review and meta-analysis, and they've done about 12 studies that they have looked at. And across all the studies, close to around 1,000 odd patients, they did say that lifitegrast improved ocular dryness score, nasal and nasal conjunctival staining reduced, corneal staining reduced, Schirmer's values improved, tear breakup improved. So both signs and symptoms across almost about 1,000 patients, which they have analyzed systematically, says that yes, this works in mild to moderate and even in severe dry eye diseases, improving ocular signs and symptoms. These are just the same side effects which have been noted even in all the studies with respect to pain, redness. Some studies did mention some kind of a nervous system problem, but the details were not available. But none mentioned specifically the need for the patient to have stopped the medication because of the adverse effect. So to summarize, it's a selective T-cell targeted therapy. It has excellent bioavailability. It has an earlier onset of action as compared to cyclosporine. Has a very good tolerability profile. Clinical studies do say that we might reduce the need for patients to use artificial tears and steroids once the patient is on lifitegrast. It doesn't require any refrigeration for stability of the molecule as such. Thank you.
Thank you, Bhaskar. I think that just sums it all, and very nice presentation. And the topic is open to discussion. I do have few questions for the panelists. I had a question for you, Dr. Aditi. Where do you see the scope of lifitegrast in your practice, especially when you have other options? And where do you use it in your practice?
So currently, the patients where I have actually used lifitegrast are mainly the patients with neuropathic pain. So just as the case of the doctor patient that Dr. Rohit had mentioned, I had a couple of patients who have undergone almost all kinds of therapies, including LipiFlow and high-dose steroids. In fact, also tried some course of oral steroids for them, and no cause could really be identified. But ultimately, when these two patients, they were exactly similar complaints. When they were put on lifitegrast, we actually saw a big difference in like 2 weeks' time. And that was something which was really an eye opener to understand that though all of the drugs, especially the cyclosporin, tacrolimus, are all working on the same principles of T cell inhibition, but lifitegrast has a different mode of action, the way it is working, and it actually really helped the neuropathic pain patients significantly. Apart from that, of course, patients with VKC, where especially in children, I think I'm going to really use it a lot now in them to see how it works, because you can't just keep using steroids in them for all the side effects that we know. And there is a big chunk of these patients that we are seeing. So definitely VKC and allergies in pediatrics. I don't know what is the age group that we are actually allowed to start with. Is it just 2+, as in most of the drugs, or we have some other guidelines for this?
So, Bhaskar, would you want to answer that?
I don't think there are any specific guidelines because the trial study was not done for pediatric dry eye. So the study guidelines are only available for adults. So and like I said, anything apart from dry eye is going to be an off-label use of the medication.
Have you tried them in pediatric VKCs and seen good results?
I think
I've not. Yeah. I've not used, I've just given it in, I think, 3 patients so far, and all 3 have been dry eye patients. I've not used it for VKC as such, even though I just wanted to first use it in the indication which it's approved for, see the response, and then try. I would probably be looking at more in terms of corneal transplant as a preoperative to kind of suppress the immune response, because you would want to reduce the triggering factor for the cells to migrate to the periphery in terms of decreasing the antigen presenting cells and the dendritic cells at the beginning of the before you take the patient up for surgery would probably be something that I would be looking at once we get a little bit more experience with the molecule.
Dr. Madhu, I wanted to ask you a question that how long do you think that you will like to continue the patient on lifitegrast, and how long do you think it will take to control the inflammation in a case of dry eye?
Ma'am, in the few cases that we have used, I think the action sets in as early as 2 weeks. And in the initial 2 weeks, I usually start off with soft steroids like loteprednol. And after 2 weeks, I taper them and keep them only on lifitegrast. And usually the treatment I continue for 3 months. And I think by 3 months is a good period for us to reassess the patient and continue the treatment.
So, has any of the panelists stopped lefitegrast after the dry eye got treated, mild to moderate, or do we continue like cyclosporin? We continue for months and then even for years.
Usually, if the patient's symptoms come down, I try to give it a break and then start again instead of doing it as a continuous thing. 3 months is so far I have given. In some cases, I have extended where the patients are still have some symptoms.
Doctor?
I have a patient who's had glaucoma drugs induced dry eye. It was quite severe, and he's been on liftigras for the past 6 months. After the first 2 months, there was a dramatic improvement of his corneal changes caused by dryness. And for the past 6 months, he's been on liftigras, and it is considerably much better than how it was earlier. Regarding the VKC, I use it in children who are above 12 years of age. And children who've been on steroids for many years, I found a dramatic effect after using liftigrast. But since there are no specific guidelines on pediatric use, I don't want to use it in children below 12. But currently, I'm using it in all my cases of VKC in children above 12.
Above 12.
So, for how many
As we are talking about VKC, Dr. Rajesh, are you there? Can you summarize your experience on vernal keratoconjunctivitis, role of lefitegrast in VKC? I think.
No. Actually, ma'am, can you just repeat the question?
So
I'm actually traveling, so I just
I know.
Yeah.
So the question is that have you tried lefitegrast in vernal keratoconjunctivitis, and what would be your experience on that, or lefitegrast in other indications, if you could tell your experience on it?
Yeah, actually, it's a little bit early to say that lefitegrast will be effective or not effective in VKCs because we have just started using it. I've just started using it in a few patients, and obviously, immunomodulators, as you know, everybody knows that. We do use cyclosporin even in people less than 16 years of age. So based on that, I started using lefitegrast because I think VKC does have a component of T cell mediated inflammation, and I think lefitegrast, based on its mechanism of action, it should work. It appears theoretically it should work on VKCs, and as cyclosporin has been used in VKCs with good effect. So, but I would say I have just started using it. In a few cases, I have used, and since all these VKCs that do have T cell mediated inflammation, it should work. But then I don't have a long-term data on this. A few patients that have started using it earlier, it was difficult to use because of the high cost. Now we have started using it, as you also have started using it now. So you'll agree that it's a little early to make a definite comment that it is really effective or not effective in VKC. But yes, theoretically, it shows promise, and I think we may use it and then see how it works, whether it works or not.
Thank you, Rajesh. Dr. Ayan Mohanta, would you want to comment on the use of lefitegrast in your experience? Dr. Ayan, I can't. Okay, Dr. Samresh, can you just tell us the role of lefitegrast if you've used in your MGD patients, because there is a component of inflammation as was being discussed?
Yes, ma'am. Thanks for the question, ma'am. I honestly, India is a very mixed bag of dry eye. So there's not one mechanism of dry eye that's walking into the clinic. And Jaipur being hot and dry in allergic season, so there's a lot of inflammatory and MGD sort of mixed picture. I do believe inflammation causes MG, meibomian gland dropout with constant rubbing and other inflammation. So there is a definite role. And in fact, just like Dr. Bhaskar was saying, there is a study on a small subset of patients, I think about 40 to 43 patients, that compared lefitegrast 5% versus vector thermal pulsation for meibomian gland dysfunction. And over a 6-week period, it showed marginally better improvement with liftigrast over thermal pulsation. So I do believe there is a role, and not only for direct inflammatory conditions, but also indirectly in these situations.
Thank you. Dr. Sujal Shah is there. If we can.
Hi, ma'am. Good evening.
Hi, Sujal. So just wanted to know, do you think it has a role? We did talk about the fact that it might reduce haze, and what is your take on it? Does it reduce haze apart from the signs and the symptoms that, it actually ameliorates?
So, ma'am, I had attended the first meeting on liftigrast by Rohit. I heard his presentation in Goa, and he discussed this antifibrotic use as an off-label or not so well-studied use, but the possibility that this might work. Exactly at that time, I had 2 post-PRK patients with early haze, both very symptomatic, lot of signs and symptoms, photophobia and other things, though they had intact epithelium, very healthy epithelial surface. Early haze had started, we were already on cyclosporin for 2 months. And it didn't work. They had a drop of at least 2 lines of best corrected vision. They were about 612. And in these people, in these 2 patients, I have started liftigrast. Within 4 weeks, they stopped calling. Their symptoms reduced. Objectively, when they came in at the 4th week visit, the haze had gone down, and their uncorrected vision had improved.
Okay.
In 3 eyes, it improved to 6. In 1 eye, it improved to 6.9. So there was still little haze, but so since then, no, I've actually started using this in along with a mild steroid in many of my to even pre-treat many of my PRK patients.
I think that is really heartening to know that it might act on cases with haze, which are very difficult to treat, and maybe in combination with tree halos. But
I did reuse tree halos. I forgot to mention because he mentioned to use both.
Thank you, Dr. Sujit. Dr. Abhishek, what is the benefit that you see with liftigrast as an immunomodulator in your practice? No, you're muted, Abhishek.
Thank you, ma'am. At the outset, I would like to thank Dr. Namrata Sharma, ma'am, and AIOSSC for giving me the opportunity. Well, the advantage that I see with my subset of patients where I've used liftigrast is, first of all, the faster onset of action. It becomes very convincing to ask the patient to continue the therapy for longer duration, unlike cyclosporin, where we keep telling the patients that the effect takes quite a long time to start. So you'll have to continue for a very long time. Second thing is lesser side effects. Patient when started on cyclosporin might complain of stinging and burning sensation. And it again becomes problem for practitioners to explain to the patient that it is one of the adverse side effects. Without these adverse side effects, it becomes very easy to continue the therapy for patients. And my most favorite is it completely eliminates the need to refrigerate the drug, unlike the neocyclosporins, which require refrigeration. I had a couple of patients who were engineering students in whom I had to prescribe this drug, and they did not have the facility of a personal refrigeration unit. So it becomes very easy for such patients to continue the drug for longer duration. And not the best, but the packaging as well. It's very minimalistic and catchy to offer a premium drug to patients as well. That would be my take on the benefits of using liftigrast in comparison with other counterparts.
Oh, thank you, Abhishek. That was very useful. Samita, I believe you have presented cases which, show dramatic improvement with cyclosporin. Would you want to comment on it?
Yes, ma'am. So thank you for having me here.
Yeah.
3 of the cases that actually have stood out in my practice so far, actually, just like Dr. Shah, I was also inspired by Rohit sir at that first meet where we spoke about haze and corneal fibrosis. So one of the patients I used it in actually had a firecracker injury to his eye almost 10 months before I saw him. And when he came, he had already he had a corneal edema and a lot of fibrosis, a lot of scarring in the anterior stroma. And he had been on everything possible. The only thing I added to his treatment was liftigrast, and in 3 months he almost went from 660 to 6.9 vision not only did the scarring reduce, but also the corneal thickness reduced back to closer to normal. So this was a patient that had been told to get a corneal transplant, and we were able to avoid that with Liftegrast. And it's the only thing I added. I did not give it an adjunct with anything else. And everything else that I gave, he was already on for 6 months, like surface steroids and Soline and other things like that. So that was very encouraging. And another patient, like someone else shared also, that a glaucoma patient on multi-drug therapy, post-trap, very, very bad surface, didn't tolerate anything, no mineral oil, no cyclomune, just doesn't tolerate anything else. I started him on Liftegrast about 3 weeks ago, and he's doing really well. For the first time, he's tolerating any drop in his eye apart from a preservative-free lubricant. So these are the two cases that I think I'm quite excited about. So let's see how it works in the future.
Thank you, Samita. And Achal, would you tell us about Liftegrast versus cyclosporin, which is the other drug in the market and which has been for so many years, especially available in India for last so many years, which we all have been using?
Hi, so having Liftegrast really accessible to us. So all of us knew Liftegrast as Xiadra, right? And it is now that Micro has come up with Sika drops, it is accessible to all of us as an ophthalmologist. So if we talk about the by and large usage in India, then practically at the level of practice, if we say that there's a head-on comparison between cyclosporin and Liftegrast, then it won't be really right about how we feel as an ophthalmologist. Indeed, there are several studies which have given inconclusive results, but practically, if I think, and what I have begun to see in my patients, because I've started to use Sika drops in several of them, the fact that it shows result almost instantaneously, even though the company says that it's 2 weeks, but by the time the patient comes in the 2 week follow-up, the patient is already comfortable. That makes it a very strong contender vis-a-vis cyclosporin, because while we are prescribing a medicine to a patient, it's not just the clinical outcome but so many other practical factors: how much the patient is comfortable with it, how economical it is, how readily it shows it impacts. That has a lot of role to play in how well it's going to be accepted in the patient ecosystem. And there I see Liftegrast as a better contender than cyclosporin, at least in conventional dry eye cases, at least in short term magic effect that we are looking for.
Okay, thank you. I think that was summed up quite well. Dr. Souvik, again, we've talked of dry eye. Would you think that the severity will have anything to do when Liftegrast can act, and which types, mild, moderate, severe, would you want to give it?
Good evening, ma'am. As Rohit has already expressed, I would like to introduce in the very beginning. Now, once the patient is diagnosed with a dry eye, because Liftegrast acts at a very early level. So I have actually put Liftegrast in more than 70 patients. And definitely those who are on mild cases, they responded very quickly within 2 weeks of administration of Liftegrast. Severe cases, they are still under trial, and they are not doing that much good, because and some of them are also with co-prescription with cyclosporin. And second point is that already we have discussed the corneal haze, and definitely it has got a very good role. Post-viral subepithelial scar, we are getting very good result. Even contact lens related corneal problem, we are getting very good results. Another point is that this is very surprising, but the US FDA needs approval for this kind of drug for improvement of only one sign or one symptom. I think so far we can discuss here today. It was a lively discussion, and we can find newer and newer application of the Liftegrast. And last, for Dr. Shetty, I think China has hit the bullseye. I think the paper has come in Eye and Vision in very latest edition, September, October of 2024, where actually they have implanted a membrane, subconjunctival implantation of a biomembrane, one side impregnated with Liftegrast, another side with cyclosporin.
That is
That is quite innovative.
That Chinese can do.
Chinese can do, my.
Yes.
Yes.
So thank
Yeah.
you so much, Dr. Souvik, and Dr. Pooja is there. Pooja?
Yes, ma'am, I'm here. Yes, ma'am.
So Pooja, lifitegrast, do you think we can give it alone? But I think you cannot give it alone. We always tend to combine it with lubricants. So which lubricant would you think it should be best combined with?
Sodium hyaluronate, because lifitegrast, everybody's spoken about where all it works. And I do believe in each of the applications, starting from VKC to corneal haze to non-responding dry eye, everything. But one thing what we have seen in our clinic is that we tried with both CMC and sodium hyaluronate combination. It works better with sodium hyaluronate. And patients accept it, patients accept it better when it's given along with sodium hyaluronate. So that is one thing I would like to say. And another thing which I can say is that we are all very much used to using cyclosporin for our dry eye patients. But what I have personally seen is that the action of lifitegrast starts much earlier, or it's much more impactful than cyclosporin in some patients of dryness, especially when they have an itch factor present. So I think a lot of patients who have not responded with cyclosporin, I've switched them to lifitegrast and they all act very well. So that is one thing I will say, but along with sodium hyaluronate.
Okay, so I think from the there's only one question which needs to be answered, which is not answered from the YouTube, and that is, can we use it in immunocompromised patients? So Pooja, would you want to answer that?
Yes, ma'am. I think we can use it for immunocompromised patients because the systemic absorption. So we've recently created a biodiffusion lab. I'm not sure whether RS have presented that because I was working on something. But we have recently started a biodiffusion lab where we are seeing if the drops when given topically are diffusing systemically or any other parts of the eye. It doesn't have systemic absorption. So yes, it can be given for immunocompromised patients as well.
So thank you, everyone. If there are any questions, Dr. Ayan Mohanta is joined back. So I think we've had a great discussion, and we just discussed the immunomodulators threadbare. Dr. Shibu, would you want to say anything?
Just one last point I wanted to add is that in early to moderate keratoconus, I've now started putting those patients on lifitegrast, and I'm just waiting by postponing the C3R treatment, trying to see how far we can postpone C3R in patients early to mild keratoconus if we put them on lifitegrast. So the longest I have now is only for 6 months. It is showing stability. So I'm just waiting and seeing whether C3R can be delayed, can be postponed by putting these patients on lifitegrast.
That's again very insightful, and thank you so much. So I think we do come to the end of the discussion, but we have a more interesting activity to do, and that is the quiz. So can we have all the quiz participants to join? And thank you everybody for sparing your time. It was really insightful. I don't think we can, whatever we've discussed today, even if we read the entire literature on lifitegrast, we are not going to know as much as we know about it today. And that too, not only alone as a standalone drug, but for various indications in comparison with other immunomodulators, whether cyclosporin or tacrolimus, in conjunction with steroids and in conjunction with lubricants. So I would like to thank all the panelists for sparing their time. And I do hope to have you on another platform at some other discussion forum in future from the AIOSSC Scientific Committee. Do have Dr. J.S. Bhalla also, member Scientific Committee, who has joined. If you would want to say anything, Dr. Bhalla, and then we move on to the quiz.
Thank you, Dr. Namrata. I think it was a very nicely conducted webinar where we could really understand from the brilliant talks of Dr. Rohit Shetty, Dr. Bhaskar, the mechanism of action of all these immunomodulator drugs and head-on comparison between various immunomodulator, tacrolimus, cyclosporin, and lifitegrast. and the discussion was excellent, particularly the off-label uses where we are still not clear whether we can use in younger patients having allergic conjunctivitis and VKC. I think the practical experience and was of great help. I think everybody enjoyed and learned a lot from this webinar, ma'am.
So thank you. And have the people who've registered for the quiz joined? Navneet, are you here?
Yes, ma'am. We can start the quiz with the presentation now.
Okay, so should I share the screen or okay?
Ma'am, you can share. Yes, ma'am. You can share the screen.
So
Yeah.
we begin the quiz. It's a short quiz, and do remain on the quiz for people who have registered because there are very attractive prizes with the quiz. And I'm sure it will not take more than 10 minutes because there are only 10 questions. The time for each question is 10 seconds to answer. Navneet, or 30
Ma'am,
seconds?
15 seconds.
15 seconds. So thank you, Sunil, for helping with this. And I would now share the quiz. So here we go. So we begin with the quiz, and this is being presented by Microvision. We would like to thank Microvision for doing this today. And the prizes are also sponsored by Microvision. So should I begin? Have all the people joined who had to join?
Yes, ma'am.
Okay. So first is going to be the warm-up question, and we begin with the warm-up question. The quiz is being played on Zoom platform. So the warm-up question is this: when is the immunomodulation webinar? 10th January, 12th January, 15th January 2025, or none of the above? And your time starts now. So Sunil, do tell me when the time is over.
Yes, ma'am. I'll announce 5 seconds before. 5 seconds left. Ending.
Okay. So I think this is the simplest questions, and there should be 100% response to this question. It is 15 January 2025, which is the date, which is today. So I'm sure everybody's got it correct. Can we go to the first question, which is the beginning of the quiz, Navneet?
Yes, ma'am. I'm waiting for your slide, ma'am.
Okay. So Navneet, are we okay?
Yes, ma'am. Yeah, all good, ma'am. I'm following it.
Okay. So get set and now go. So the first question is, which is the first and the only approved drug by US FDA for the treatment of signs and symptoms of dry eye? So if you did listen to the webinar, you would be able to answer it. Cyclosporin, lifitegrast, tacrolimus, and trehalose. So your time starts now. So I think this is an easy question. I know it is a confusing question, but I'm
5
sure
seconds.
you will be able to answer it. So the time is
Closing.
closing. So it is closed. So I hope everybody's got this correct. It is lifitegrast. So there is a difference by US FDA for treatment of signs and symptoms of dry eye is lifitegrast. For management of dry eye, it was cyclosporin. So we come to the next question, which is question number 2, and all the answers which are there in the all the answers of the quiz were actually there in the presentations if you did go through these. So the question number 2 is lifitegrast achieves higher ocular surface bioavailability because of hydrophilicity, specially formulated with addition of sodium ion, isotonic, or all of the above. So can we have the timer, please? So somebody has to say tick, 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 so that we have the timer next time on the
Yes,
audio.
ma'am.
So
5 seconds, please.
So I think this is again a very simple question. If people have attended.
Closing.
Okay, so the answer as expected is all of the above. So even if you didn't know these three and you just ticked all of the above, you would still get it correct. We come to question number 3. The question number 3 is again a simple question. What is the recommended dosing of lifitegrast? This was a question which was also there on the YouTube channel, but I did not answer it because I knew that this is there in the quiz itself. So is it OD, BID, TID, or QID? And your time starts now. So if you've listened to Dr. Bhaskar's talk and Dr. Rohit Shetty's talk, you would be able.
5 seconds.
So the answer is the BD dose. So it
Done.
has to be done twice a day. Question number 4 is, as per the Opus 3 study, lifitegrast showed onset of action in terms of symptomatic relief in how many days? Day 45, day 14, day 25, or day 30? Can we have the timer, please?
Ten seconds. 5 seconds. Closing.
Okay, so this was there in the slide, but probably not spoken about, and the answer is day 14. The next question is, the only active controlled phase 3 clinical study in the world with lifitegrast is published in which journal? Delhi Journal of Ophthalmology, Taiwan Journal of Ophthalmology, Indian Journal of Ophthalmology, or American Research and Vision in Ophthalmology, that is ARVO. And your time starts now. This is again very simple.
Ten seconds. 5 seconds left. Closing.
Okay. So the answer is Indian Journal of Ophthalmology, our good old Indian Journal of Ophthalmology, multi-centric trial from various centers across India on lifitegrast, published with one of the highest number of cases. Question number 6. Lifitegrast stops inflammatory cycle in dry eye by blocking T cell activation, preventing activated T cell migration, inhibiting the cytokine release, or all of the above. Time, please.
15 seconds. 10 seconds. 5 seconds left. Closing.
Okay, so as expected, the answer is all of the above. So when you are in confusion and you don't know what to take, it is best to do all of the above. So question number 7 is, lifitegrast targets and blocks T cell activation by blocking LFA1, ICAM1 interaction, blocking the production of cytokines, inhibiting the phosphatase activity of calcineurin, or all of the above. The timer, please.
15 seconds. 10 seconds. 5 seconds left. Closing.
Okay, so the answer is blocking LFA1, ICAM1 interaction. The next question is question number 8. The globally approved formulation of lifitegrast is available in multi-dose preserved vial, unit dose preserved vial, multi-dose vial, or preservative-free unims. Timer, please.
15 seconds. 10 seconds. 5 left. Closing.
So the answer is preservative-free unims. So there are no preservatives which are present in the currently available Sika drops which are available from Microvision. Question number 9 is, lifitegrast 5% ophthalmic solution with unims does not require refrigeration. True or false? So if you've really heard the webinar, you would know this instantly. Time, please.
15. 10 seconds. 5 seconds. Closing.
Okay, so I think this was also discussed by Dr. Abhishek. It is true that it does not require refrigeration. The last question of the quiz is, what makes lifitegrast different from other immunomodulators? New formulation, site-specific mode of action, early onset of action, all of the above. Timer, please.
15 seconds. 10 left. 5, please. And closing.
So thank you, Sunil, and the answer is all of the above. So with this, we will now tabulate the results. Thank you so much. Can we have the video while the result is being tabulated, Navneet?
Ma'am, because this will take little time from the Zoom to pull out the answers, and then tabulation is needed. So we can declare the results.
We
Yeah,
can play the video now. Then you can.
yeah. Mr. Sunil, yeah.
So thank you for that. And we have to declare the results, and there are attractive prizes which are going to be sponsored by Microvision. We are tabulating, and do we have fastest fingers first also in this, Navneet? You have to work out on that. So
Yes, ma'am.
anyway, we will be declaring the results in our next webinar. And so till that time, do stay tuned in, and we would do it in few days. So thank you so much, everyone, for joining. And we would like to thank Microvision, particularly particularly Navneet and Ashok, for helping with this entire webinar. And of course, I would be failing in my duty if I don't thank my AIOSSC scientific committee members, as well as Mr. Sunil, who manages the entire audiovisual thing during the webinar, and also the AIOSSC headquarter team and the scientific committee team, the secretariat staffs, Mr. Kripal and Mr. Bhupender. So thank you, everyone, and again, hope to meet you on another platform with another topic which is going to be as exciting. Thank you.